Hi, this is Annalise Murphy and Maggie Sievers. We are students at the University of North Florida currently pursuing our Doctorate of Nursing Practice in Nurse Anesthesia. Today we are going to be discussing the effectiveness of paravertebral blocks in reducing chronic pain syndrome following breast cancer surgery. The objectives for this presentation will include discussion on the background of chronic pain syndrome that is associated with breast cancer surgery, a presentation of the current evidence on the effectiveness of paravertebral blocks in reducing the incidence of chronic pain in this patient population. We will also discuss the clinical implications in current practice, and finally, a discussion of paravertebral blocks. It is estimated that in 2016, almost 250,000 women received a new breast cancer diagnosis. In 2013, approximately 3 million women in the United States were living with breast cancer. In patients who undergo a breast cancer-related surgery such as lumpectomy or mastectomy, up to 68% will develop a chronic pain syndrome. Chronic pain associated with breast cancer surgery is described as a complex interaction between biological, psychological, and environmental factors that occur during the perioperative period. It is caused by direct nerve injury and may be the result of injury to any one of the many nerves that innervate the chest and axilla. Surgical procedures that involve the upper outer quadrant of the breast and axilla are more prone to nerve injury due to the concentration of nerves in this area. Risk factors for developing chronic pain syndrome include the following: severe postoperative pain scores, the age at diagnosis. Younger patients are more sensitive to nerve damage, less likely to tolerate pain, and have increased levels of anxiety. This factor may also be related to more aggressive treatment experienced by this younger population. The population is difficult to define as there is not a consistent age that determines a younger patient among the current evidence. Radiation therapy. Some studies have found that patients who undergo breast conservation therapy, including partial mastectomy, axillary node dissection, and radiation therapy, have a higher incidence of chronic pain than those patients who have modified radical mastectomy with no radiation treatments. The type of procedure. Axillary node dissection is often the reason for chronic pain because of the intercostobrachial nerve. There is greater incidence of chronic pain following axillary node dissection than sentinel lymph node dissections. The surgical treatment approach, for example, partial mastectomy, total mastectomy, or multiple breast procedures, etc., was not associated with the development of pain. Psychosocial factors such as anxiety, depression, sleep disturbances, catastrophizing, somatization are all associated with development of chronic pain. Pre-existing pain, not necessarily related to a breast cancer diagnosis or the surgical site, is also associated with the increased risk for post-mastectomy pain. The clinical presentation of chronic pain syndromes can vary widely. Chronic pain syndrome can develop early in the postoperative period or may be delayed. Characteristics of chronic pain syndrome are typically neuropathic in nature. These symptoms can be localized to the operative site but may also include the ipsilateral arm, shoulder, and chest wall. Nerve injury can cause decreases in range of motion and shoulder strength, and these can interfere with activities of daily living and the quality of life. Chronic pain syndromes can last months to years and can be very difficult to manage. The current practice for management and prevention of chronic pain syndrome widely varies. We should implement a shift in focus towards preventative analgesia as opposed to reactive analgesia. The following PICO question drove our literature search. Do patients undergoing unilateral breast surgery who received paravertebral blocks compared to patients who do not have reduced incidence of chronic pain syndrome? Time was not a factor for this PICO question. Keywords from this PICO question were used to search 4 databases. These included Cochrane, PubMed, CINAHL, and ProQuest. Search terms included unilateral breast surgery, paravertebral block, chronic pain syndrome, and reduction of postoperative pain. Our search resulted in over 700 articles, which we narrowed down to 4 relevant to our PICO question. The following information includes the critical appraisal of the current evidence that we have found. Karmakar et al. Completed a randomized controlled trial and found that overall incidence of chronic pain in patients who received thoracic paravertebral blocks versus general anesthesia was not significantly different. However, secondary symptoms such as chronic pain scores and signs and symptoms of chronic pain were decreased. Overall physical and mental health were also improved in patients who received thoracic paravertebral blocks. Ilfeld et al. Also completed a randomized controlled trial and found that at 3 months follow-up, there was no significant difference between the intervention group, who received the paravertebral blocks, and the control group. However, at 12 months post-op follow-up, the incidence of chronic pain in the control group was 47%, compared to 13% in the intervention group who received thoracic paravertebral blocks. Karaluma et al. Conducted a randomized controlled trial and found that pre-incisional paravertebral blocks reduce the prevalence and severity of pain 1 year following surgery, specifically in regard to motion-related pain and chronic pain symptoms at 12 months post-operation. Shimzu et al. Completed a follow-up cohort study and found that patients who received paravertebral blocks had a decreased incidence of chronic pain when compared to patients who did not receive paravertebral blocks. We've conducted a critical appraisal of these articles and found that all of them consistently provided evidence that the use of pre-incisional paravertebral blocks in patients undergoing breast cancer surgery decreased the incidence of chronic postoperative pain. Overall, these studies found a decrease in incidence and severity of chronic pain and an improvement of quality of life related to chronic pain in patients who received these paravertebral blocks. These findings can be generalized due to the diverse nature of study origins. These studies were based in China, the United States, Finland, and Japan. Cultural and racial bias did not account for the patient outcomes. Based on the findings of these studies, it is recommended that pre-incisional paravertebral blocks be utilized for patients undergoing breast cancer surgeries. Increasing the use of paravertebral blocks for breast cancer surgery is cost-effective, carries minimal risk to key stakeholders, and leads to positive patient outcomes. We identified the key stakeholders as anesthesia providers, patients and their families, and the surgeons who perform breast cancer surgery. The risks associated with paravertebral block are similar to those assumed with breast cancer surgery themselves. Current use of these blocks include radical mastectomy and occasional partial mastectomy. They are not used for lymph node dissection, lumpectomy, or routinely for partial mastectomy. Thank you for your attention. Please direct any questions or comments to the authors of this presentation at the email addresses provided.